Gracias. When we speak about COVID-19, we think, of course, first at the respiratory failure. And this is one study among many showing data on gas exchange, the severity of hypoxemia, the PEEP level, but it tends to consider that respiratory failure is a single homogeneous problem, which is not really the case. We have now modern ways of applying various forms of respiratory support, including non-invasive mechanical ventilation, high flow oxygen, helmet for CPAP, or even non-invasive mechanical ventilation. Yeah. And we have even learned that these non-invasive methods would not prevent the use of prone positioning in severe cases. This is true for non-COVID, but it has been shown to be applicable in COVID as well. Yeah. However, when the patient gets worse, we should appreciate the limits of non-invasive support and select the right time to intubate the trachea when necessary. It is not so easy to intubate the trachea of a COVID patient, but sometimes we have no choice. Because if we wait for too long, there may be respiratory arrest and even cardiac arrest with the terrible consequences. So we need to evaluate the clinical status of the patient to choose the optimal timing. But we must also take into account the availability of equipment, respirators, or just bed availability, and the personnel. And we also need to take into account the ethical decisions which are related to age, comorbidities, and other factors. Now, Professor Gattinoni will address it in detail, but at the beginning, people were primarily focusing on ARDS associated with COVID. Well, we could even wonder whether the syndrome can apply, because when we developed the modern criteria in Berlin, we proposed that the ARDS should be of acute onset within 1 week of a known clinical insult. And here, ARDS very often develops more than 1 week after the beginning of symptoms. But more importantly, the use of thoracic CT scan has shown that the pictures are not always typical of ARDS, as we would see here on the right side of the slide. We usually see several lesions in the lungs, and of course the lesions can change over time to spread out and then hopefully resolve in the best cases. So respiratory failure in COVID-19 is far from homogeneous. It can take different different characteristics. So Professor Gattinoni will certainly discuss it further, but the respiratory management is not just the management of ARDS. Many of these patients do not have a low thoracopulmonary compliance, and we may afford a larger tidal volume than in classical ARDS. That's how Professor Gattinoni referred to the type 1 respiratory failure, which is not the typical ARDS, and the type 2 that usually develops in later stages. So this shows that we should personalize our therapies of respiratory failure. But COVID-19 is not just respiratory dysfunction. The virus can influence and alter the function of virtually all organs. Circulatory shock is relatively common, although it is usually not very severe. Circulatory shock can be due to any of the 4 mechanisms: hypovolemia, cardiac problems, major pulmonary embolism, although it's not very common, and especially distributive shock associated with the so-called cytokine storm. So if I quickly go over these organ dysfunctions, people have described with a various frequency the so-called acute myocardial injury associated with increased troponin levels. Cardiac output may be reduced, not necessarily because there is an abrupt decrease in contractility, but sometimes it is due to insufficient cardiac preload associated with hypovolemia. Because by fear of the lung edema, too often some people have limited fluid administration in these patients who had fever, they have not taken enough fluid, and they sometimes add diuretics to that, and this can result in significant hypovolemia. That's how at the beginning sometimes people described severe cardiovascular collapse following endotracheal intubation because venous return to the heart was acutely reduced. So that if the patient is suspected of being somewhat hypovolemic, a fluid challenge should be performed, and fluid administration should be stopped if there is no positive response. Some people may prefer to use the passive leg raising, but it is not an easy procedure, as you need to document a very transient increase in stroke volume when you raise the legs. It's not so easy. So we sometimes have to use a little bit of dobutamine to increase cardiac output. Measuring the Scv O2 can be helpful because when it's low, in the absence of severe anemia, it can be a clue to indicate that cardiac output is not sufficient. The Coagulopathy is very common in COVID-19, and the first indicator is a moderate reduction in platelet count. We learned already quite a long time ago that there is an interplay between coagulation and inflammation in what we call endotheliopathy, and this can result in organ failure. And this is very important in COVID-19, as shown in this paper that was just published yesterday in the New England Journal of Medicine. So people would like to have a drug like activated protein C, but it is no longer available today. Pulmonary embolism is quite frequent, although it is usually not massive. This is our own experience with 1/3 of COVID-19 patients having pulmonary embolism diagnosed on chest CT scan. Alterations in renal function are quite common as well. And the pathophysiology is relatively complex. I spoke about the decreased renal blood flow, but it could also be a direct viral cytotoxicity, an immunologic injury, or indeed microangiopathies. This is a very interesting study just published yesterday, showing that the virus can be found in virtually any organ, including the kidneys. Finally, there can also be an alteration in the mental status, completing the picture of multiple organ failure. So we can speak about a viral sepsis, because sepsis is the combination of an infection with organ dysfunction. An infection can be viral as well as bacterial. So it's interesting to note that in COVID-19, bacterial infections are not very common, at least in the initial stages. This is in contrast to other viral infections like in influenza infections. Finally, I would like to stress that mortality is actually quite complex to assess. Globally, patients who have COVID-19 plus mechanical ventilation may have a mortality rate exceeding 80%. But sometimes, as I alluded to initially, it could be because we are overwhelmed with a surge of patients and we can no longer treat them as well as we would like to. So this raises important ethical questions when there is a lack of resources, lack of ICU beds, lack of nurses or respirators. When there is a disaster, the quality of care can be decreased, and in the presence of pandemics, we may not even have the opportunity to transfer the patient to other institutions because everybody in the region is very, very busy. So we have no choice to try to keep patients outside the intensive care unit when they are not too severely ill, or to allow them to die when they are too sick. So we should do whatever we can to expand the number of ICU beds, going to the pediatric ICU, to the coronary care unit to try to expand the number of beds. But sometimes we have just no choice, and if there is too much pressure on the ICU, we must limit our actions. If we need some extracorporeal membrane oxygenators, but if they are already used, what do we do? Or if it's just a lack of respirators. In our country, the OD cars started to make respirators. What do we do when there is a lack of nurses? We try to bring some nurses from the operating room and other departments, but they may not know the work in the ICU very well. Very importantly, we should not focus only on COVID-19 patients. In Italy, like in France, sometimes they realized that they denied ICU admission for some patients who really needed it and who did not have COVID-19. And we need to take into account not only the age, but the degree of comorbidities and the patient's preferences. Like here, this elderly patient said, no, I don't want to go on the respirator, keep it for someone else. So we need to have a process to prioritize admissions, and this should be as objective as possible. In North America, they like to use scores, and the SOFA score in particular, to focus on patients who are sick enough to be in the ICU, but not those who are about to die. So there should be a team leader who should act with transparency, so we know how the decisions were really made. And very importantly, we should not apply the principle of first come, first served. In some countries, they initially admitted many patients in the ICU as long as beds were available, and then when the ICUs were full, they were stuck. We must have the possibility to stop therapy in patients who are already in the ICU. So if no respirator is available, sometimes we must be strong enough to take the respirator of someone who is not improving and who is about to die, regardless of our efforts. Because if the patient is frail, has no life expectancy, really mechanical ventilation is not going to help. So that's how I wrote this paper on understanding the pathways to death in patients with COVID-19. Because we may consider that some patients should not go in the intensive care unit, or should not be mechanically ventilated, or could be mechanically ventilated but should not go on ECMO. So there must be some limitations at one time or another for virtually every patient. That's how it is so difficult to interpret mortality rates. In COVID-19, in ICU patients, we need to look at the list of items here. What is the predominant terminal organ failure? Sometimes it's a patient with terminal heart failure being infected. We need to look at the proportionality of care in the dying process. And we need to look at the involvement of COVID-19 in the dying process. Some patients may die from something else, but be infected with the virus. So these aspects are terrible, very difficult to manage, and we need to support healthcare personnel. You can see here Rocio at the center of the picture with the team of the ICU. Finally, if you like, we can say a few words about the treatments. We do not have very much to offer. This is, by the way, an excellent review by Dr. Sanders. There have been many discussions about hydroxychloroquine, but we must admit that there is no good evidence that it really works. This is our review with Professor Taccone and myself on this issue. Yesterday in the Lancet appeared this big study on patients treated with hydroxychloroquine. And the risk of death is increased in cardiac patients, in very hypoxemic patients, and in patients treated with hydroxychloroquine. And these patients are more likely to develop ventricular arrhythmias. Remdesivir as a new antiviral agent has been shown again yesterday in the New England Journal of Medicine to bring a very modest improvement. It will be a very costly medication for a very minor benefit. There is a lot of interest today for convalescent plasma following a few cases. There is now a lot of enthusiasm in the world for this particular strategy. I could speak about other therapies. There is a lot that we could try. This is just colchicine, but there are many different options. And there may be a place for blood purification techniques, allowing to eliminate the cytokines which are released in excess. So we should work better at the international level, and this is true for Europe, this is true for Latin America, this is true for everywhere. So I think I will stop here. Muchas gracias.
Vamos a tratar de ser bastante breve. Un honor estar compartiendo con los profesores a nivel mundial, doctor Vincent, doctor Gattinoni. Esto con Perú hemos partido muy simultáneo a fines de febrero, comienzos de marzo, y en estos momentos estamos viviendo momentos muy difíciles. Este es uno de los primeros pacientes que nosotros tuvimos, que ingresó el 15 de marzo, este paciente ingresó a nuestra unidad, y ustedes ven que es una radiografía relativamente, tiene pocos infiltrados, pero es un espanto, como 3-4 días después se producen estas consolidaciones que no tenemos claridad. ¿Qué es lo que las produce? Sin duda la carga viral, factores genéticos, pero hay un tema que nos preocupa, que es la ventilación. Estos pacientes comienzan a ventilar y esto no es algo nuevo, es lo que hemos llamado, descrito como daño inducido por la propia ventilación. Es el exceso de ventilación, la hiperventilación, el aumento de trabajo ventilatorio, los grandes esfuerzos pleurales que van a generar una elongación patológica y que sin duda dañan el pulmón. De manera que se planteó precozmente cortar este círculo vicioso con una intubación precoz, de manera que el paciente llega con taquipnea y con hipoxemia, intubar al paciente. No compartimos la experiencia que hemos tenido en el último tiempo. Probablemente tenemos algunas herramientas que se las quiero presentar. Yo prefiero mirarlo de esta manera. Este es el centro respiratorio que activa la musculatura ventilatoria. El virus genera un daño en el pulmón y la respuesta inicial es hiperventilación. Y la hiperventilación, el aumento del trabajo, este aumento de las presiones pleurales, daña. El soporte inspiratorio, poner por ejemplo CPAP o ventilación controlada por volumen, puede ayudar a disminuir la disnea, pero no frena este mecanismo de daño. En cambio, hay algunas terapias, por ejemplo, la posición prono, el uso de PIP, que pueden disminuir el espacio muerto y por ende hago más eficiente mi ventilación. A la misma ventilación alveolar me disminuye el volumen minuto, me disminuye el estiramiento del parénquima. Estos son datos que, si esto es distreo o no, yo creo que es un problema semántico. Nosotros tenemos un paciente con neumonía por COVID, que es una patología nueva, y lo que sabemos es que en general, y esto lo hemos visto también, nuestras unidades en estos momentos están llenas de pacientes con COVID, que tienen en un comienzo distensibilidad preservada. Esto es lo que han hablado de hipoxemia feliz, que el paciente está con hipoxemia, pero ventila sin gran disnea, 28 por minuto. Entonces, ¿cuándo intubar? La taquipnea per se no es una indicación de intubación, tampoco la hipoxemia ni la PAFI. La relación PaO2, FiO2 es un marcador de gravedad, no es indicación de intubación. Y hemos visto que hay pacientes que llegan con 25 por minuto o 20 por minuto, una PAFI de 140 y lo intuban. El trabajo que daña está dado por el impacto de la magnitud del esfuerzo. Cuando ustedes ven que se activa el esternocleidomastoideo, ese paciente se está dañando. Y eso es lo que hay que frenarlo. Y podemos hacer cosas. Y esto es lo que estamos trabajando nosotros en este momento. Una de las terapias de los últimos 10 años que le ha ido ganando espacio a la ventilación no invasiva, al CPAP, es la cánula nasal de alto flujo. Y estos son datos de FRAP, en que la mayoría de estos pacientes son pacientes con neumonía. Obviamente no neumonía por COVID, porque esto es una patología nueva, pero neumonía al fin y al cabo. Y la cánula nasal de alto flujo, además de ser muy bien tolerada, ya ha dado muestras de que disminuye la frecuencia respiratoria, y esto es básicamente porque disminuye el espacio muerto, de manera que hago, lo que les digo, más eficiente mi ventilación. Puedo disminuir el volumen minuto, el trabajo ventilatorio y disminuir el daño inducido por la propia ventilación. De manera que si volvemos a nuestro cuadro, en términos del centro respiratorio, la activación de la musculatura, la ventilación no invasiva te puede ayudar en la musculatura, pero también con todas estas interfaces puede aumentar el espacio muerto. En cambio, la cánula nasal de alto flujo, la posición prono, tienen un efecto que va al meollo del asunto, va a disminuir el espacio muerto y por lo tanto me permite una ventilación más efectiva. Al principio teníamos muchos miedos por la aerosolización, de la dispersión de las gotitas del virus. Hoy día lo que estamos haciendo es poner la cánula y una simple mascarilla. Esta simple mascarilla inmediatamente disminuye la aerolización del virus. La otra terapia es el prono. Este es un paciente que tuvimos nosotros. Ustedes ven aquí un paciente que llegó con una imagen. Este paciente ya está intubado. No es un paciente en ventilación espontánea, pero estamos haciendo algunos estudios, estamos midiendo diferentes cosas. Y a la derecha ustedes tienen los mapas de perfusión en rojo y de ventilación en azul, arriba en posición supino, que no se correlacionan muy bien. Sin embargo, en la zona baja, ustedes ven que al pronar el paciente, el centro de la ventilación coincide con el centro de la perfusión. El prono tiene una larga experiencia en el paciente ventilado que puede optimizar la relación ventilación-perfusión y por ende disminuir el espacio muerto, disminuye zonas de Chan y disminuye también espacio muerto. De manera que si logramos hacer estas dos cosas en los pacientes desde el momento en que nos llegan a la urgencia, vamos a evitar algunos pacientes que requieran ser intubados. Y un paciente que no requiere ser intubado permite dar espacio a un ventilador para otro paciente que sí lo requiera. Es una forma eficiente. No tenemos seguridad. Ya mostraron estos primeros datos ahora en Llama, que acaban de salir un par de estudios a corto plazo que muestran mejorías espectaculares con la posición prono. Sin embargo, obviamente hay un tema con la comodidad del paciente, pero yo creo que esto es como tomar sol en la playa. Tú te acuestas y te vas acomodando, te mueves a la derecha, a la izquierda y toleras lo que más puedes. Estos son los datos que tenemos nosotros y les pido, yo he puesto por ahí a alguien que ha preguntado por ahí la página que nosotros tenemos en estos momentos y que creemos aquí a la derecha que el prono más la cánula nasal de alto flujo en conjunto precozmente al disminuir el espacio muerto pueden cortar este círculo de mayor agravamiento. Aquí a la izquierda tenemos un paciente que ustedes ven la imagen del escáner terrible y el paciente está ahí acostadito, bien cómodo en la sala de urgencia. Al medio, una chiquilla joven. Ustedes abajo se ve que está jugando con el celular. Y arriba ven la saturación en el 87. Esa niña estuvo 5 días en posición prono y se fue de alta ayer viernes. Se mejoró pudiendo estar en este momento en ventilador. Y los pacientes que caen en ventilador están un largo tiempo. Esto para nosotros es prono independiente de la interfase. Ojalá con cánulas nasales de alto flujo, que en estos momentos las tenemos todas ocupadas en el país y estamos tratando de importar en estos momentos. De manera que con nuestra Sociedad Chilena de Medicina Intensiva teníamos este protocolo que cuando llegue al paciente a urgencia ponerle una oxigenoterapia, bigotera, Venturi y si aumentaba el trabajo, cánula nasal. Desechamos el uso de aparatos de ventilación no invasiva, aunque por varios problemas, pero preferimos la cánula nasal de alto flujo porque es la que ha mostrado más utilidad en los últimos 10 años. Y en este momento estamos cambiando este protocolo, poniendo a los pacientes en prono precozmente desde que pisan el servicio de urgencia. Y esto, la experiencia inicial, si bien no tenemos aún datos tabulados, es que hasta un 40% de los pacientes pueden rescatarse del ventilador. De manera, el mensaje es esto: la indicación de intubación y conexión al ventilador es un aumento del trabajo respiratorio. No es la taquipnea, no es la relación PaO2-FiO2, ese es solamente un marcador de que el paciente tiene un trastorno de oxigenación, pero no es indicación. La indicación es el paciente que tiene un aumento del trabajo respiratorio por actividad de la musculatura, tiene compromiso de conciencia, tiene evidencias de hipoperfusión, lividez. Pero el paciente, si a usted le llega un paciente con frecuencia de 35 por minuto, desaturando, póngale oxígeno, pónganlo en prono, intenten el prono vigil, porque van a salvar pacientes y van a lograr frenar esta terrible ola que nos está afectando en todo nuestro continente. Un saludo cordial a todos los amigos del Perú y de Latinoamérica que nos estén escuchando y voy a estar disponible ahí al que quiera hacer alguna pregunta a través del chat o de las interfaces.
Do not understand the mechanism of the disease, is impossible to have a proper treatment. Second, here we have one specific disease, and we have a lot of different observation, which is quite strange. because it's not a syndrome, it's a disease. And why we have so different experience? You know, Jean-Louis presented before, mechanical ventilation, 83% mortality. We know, I know personally, units in which the mortality was 10%, and I know units in which the mortality was 100%. Somebody is 30%. So that means that maybe the treatment play a substantial role. And as we do not have any real cure for the virus, but our own defense, what we have to do is to keep the patient alive without damaging. And I think that many things that I heard around the world, in my opinion, we did, or somebody did, a lot of damage to these patients. So let me start with, this is the first, to me, the most impressive consideration on this disease. You see on the left, we have the pneumonia. Well, on the left, we have the compliance here. And you see that about more than 50% of the patient, and now this is a little sample, but this has been confirmed with hundreds of patients, more than 50% have a compliance which is near normal, despite a tremendous amount of shunt. Look here, we have patients with a venous admixture greater than 50, up to 60%, 70%. But you see some of these patients, because this disease changes rapidly with time. There are about, we are just examining about 400 patients coming in Sacco, in an hospital in Rome and one in Milan. About 45% of the patients presented hypoxemic. That means with a PF below 300 without any dyspnea, without any particular syndrome, but cough, 80%, and fever, 85%. But they felt absolutely not dyspnoic. Now, my dear friend, we may call it RDS, but I think I play with RDS since 40 years. Now, it's not the problem to call RDS or not call RDS. I think I don't care. But the problem is that many people say, okay, this is severe RDS, so I have to treat as usually I treat severe RDS. That means low tidal volume and high PEEP. Okay, let's see here. Now, look at this patient we have seen already. Here you have some infiltrates, okay, and here we have a far more severe picture. Here the PF is 166, lung weight is 900 grams. Here the PF is 164, same. Lung weight is 2 kilos. Here, the compliance is 27. Here, the compliance is 60. You see that is a completely different picture of what at least I saw in all my life. Look this one. Here, under severe RDS, excuse me. This one, very severe RDS, 100, exactly as this one. The lung weight, 2 kilos and under 50, 2 kilo, compliance 67. And here is compliance is 55. Now, what is how is possible to conciliate, to put together this gas exchange and this lung mechanics. Now, I think we have to realize, excuse me, because they go alone, we have to realize that we start with an endothelial inflammation. While the normal pneumonia, the assault is to the gas space of the alveoli, here the virus assault is in the perfusion part of the alveoli. So we have endothelium inflammation, hypercoagulation, which is tremendous in these patients. Heparin is fundamental to keep this patient alive. And in the other side, we have the complete loss of vasomotor tone. And we have a huge ventilation perfusion mismatch and hypoxemia. Okay, and this is a little complicated, but we are accumulating evidence that the perfusion goes in one side and the ventilation goes in another side. And this is why these patients are hypoxemic. They start to breathe a little bit more, but they do not feel dyspnoic because the compliance is very good. So the gas, the lung is full of gas at the beginning, at least. And this is the ventilation perfusion mismatch. So when we have hypoxemia and other factors which are linked to the virus, to the inflammation, cytokine, and are not very clear, you have an increased respiratory drive, and we have an increase in tidal volume. And now, why these patients are not dyspnoic? Some are not dyspnoic because until you expect 600 and you get 600, you don't have any dyspnea. If you expect 800 and you get 800, you don't have dyspnea. You have dyspnea when your brain expects a big tidal volume of 800 and you can get only 600. This is the origin of dyspnea, which is an absolutely personal feeling. So at the beginning, this patient we call type 1 or type L light. They have a good compliance, that means low elastance. They have a very bad oxygenation because of the AQ mismatch. They have the lung weight, which is pretty normal, and the recruitability is very low in these patients. So some patients just stop here. But let's see, a patient like this maybe come into the hospital. They take the saturation and they found 89 saturation. Blood gas is very low. What does the doctor? Jump on the patient, which maybe is breathing without any dyspnea, and put helmet, cask, and whatever, with this Pavlov reaction to correct hypoxemia. Hypoxemia is a sign of a more complex disease. You have to be careful before to jump on the patient, just looking at hypoxemia. You have to look all the patient conditions. Okay, now let's assume that the patient have a quite continuous breathing. Bugedo already spoken about that. A continuous breathing without no dyspnea, but big pleural swings. We may have some edema after 24, 48 hours of this kind of breath. So at this point, you may start with non-invasive support, including prone position. If the patient stops the vigorous effort, leave the patient like this. Is no problem. The patient is maybe happy. What is important to decide intubation, yes or not, is the inspiratory effort that the patient makes. is not the oxygenation. And you know, and we do this just to stop the personal induced lung injury. At this point, we don't need a big PEEP. We have to sedate the patient and to keep the patient quiet to stop the personal damage. But remember, it's also possible that the disease proceed by itself. But we can do nothing about that. The only we can do is try to limit the self-induced lung injury. So if we continue in this way, we arrive with the patient with a low compliance, shunt, the lung weight increase, and high recruitability. The recruitability increase, but is never very, very high in this kind of patients. Okay, excuse me. If a doctor is used to say the patient at the beginning, they found the lungs are flexible. If the doctors are used to say patient in this stage, they say, oh, but this is ARDS. I have to treat as normal ARDS. This is the confusion that we have at the moment. A sort of ideological battle is or not is ARDS. Okay, give me an example. This is a friend of mine who died, and he started this way with a PF 95. Look at the CT scan. The lung was perfectly aerated. There are nothing in a bad lung. After 7 days of mask, CPAP, NIV, tremendous inspiratory effort, this was the PF. Look at the CT scan. Look at the quantitative CT scan. Now, it's of course possible that there is the virus contribution, but how much is the doctor contribution? If you take a patient like this and you say this is RDS and I use 20 of PEEP because I use the PEEP FiO2 table, I may kill this patient. But you know, remember, the oxygenation is the same. Of course, the mechanisms are different. But if I found this is severe RDS according to Berlin, but the compliance was good, and if you go in a Massachusetts General Hospital, and my friend Taylor, they say, of course it's the RDS. And I have to treat according to the RDS, because we believe in the evidence medicine. We are building evidence here. We cannot use a wrong evidence from other fields. So, spontaneous breathing, negative pleural pressure, progression of the disease, or virus and the biology, thrombosis, progression of the disease. What we can do? I think the only thing we can do is try to stop the ventilator-induced lung injury. There is no one in the world that measures the esophageal pressure in these patients. I know there are overwhelming patients coming and so on, but if we do not understand and if we do not measure, we cannot treat right in the patient. Or at least to look at the CVP deflection, or look at the inspiratory muscles. This is because this is the only thing that we make correct, together with the anticoagulation. That's all we can do. So, when we have the patient with this kind, non-invasive support, if the effort persists, to me, this is the key point for the intubation, yes, and intubation, not. Not to substitute the respiratory muscle, because this patient breathes perfectly alone, but to impede the self-induced lung injury. We know from animal studies, we know since 1938, that this is a tremendous possibility of increasing edema and to shift to far more severe condition. So non-invasive support, if effort persists, mechanical ventilation to prevent the self-induced lung injury. You'll see that the mortality of this patient decreased a lot in therapy, intensive care, in Italy at least, because at the beginning, these patients were treated with high PEEP outside the intensive care, and maybe was breathing as a hell for 3, 4, 5 days. Now we have more space, the people learn, there is no reason to superinflate the patient, and you see that the mortality rate, natural mortality rate of this disease should not be greater than 20%, not 80%, my dear friends. What kind of mechanical ventilation? And everybody, FiO2, high as needed, the minimum. You don't need under 20 of PO2. If you have a 65 of PO2, is more than enough if you have a saturation of greater than 90. Tidal volume. This is a big scandal. But in a perfectly compliant lung, I don't know why I should use a tidal volume to reduce hypercapnia. I can use easily 7, 8 milliliters per kilo in this condition. Respiratory rate and PEEP not more than 10. And I think the minimal PEEP consistent with a decent gas exchange, because also the VQ respond to PEEP. When you have the transition, we don't have two individuals, but we have a transition of from L and H. So we have you can call 200 subtype, but these are two extremes of a spectrum, and here you can use exactly what you use in RDS. Still be careful with PEEP, because the impression we have, now we have some study in which very accurately we measure lung mechanics, PEEP response, and so on. These patients have, still in this condition, have a quite high lung volume. They look as the baby lung become emphysematous, and they are very sensitive to the hyperinflation. And when you go from PEEP of 5 to 15, you may have a tremendous decrease in compliance. Here the compliance starts reduced, but is very sensitive to the pressure. Of course, a prone position is whatever you do bad to the lung is less bad in prone position than in supine position. So prone position is always good. So winning, be careful, because if you think to the normal RDS, you connect the patient, the gas exchange is good, the PCO2 at the beginning is good. Be careful when the PCO2 goes up with days, is a sign of these patients are very sensitive, very prone to the fibrosis and to microthrombosis, and both contribute to the rise of PCO2. You have to be patient, because this lasts long. And if you try to disconnect the patient early, you have to reintubate maybe, or to start again everything. So early weaning may be problematic also for what Jean-Louis said before. This is not a lung disease. The lung is the primary target, but it's a systemic disease. It's an endothelial disease. So fibrosis, cysts, blebs, pneumothoraces are far more frequent in this patient than in typical RDS. So be careful with the name and with the treatment and with the protocol. To me, to apply the classical protocol for RDS may be very dangerous in some patients. You have to personalize, to classify this particular individual. Long course disease, be careful with PEEP, extremely careful with PEEP, because the recruitability of this patient is very low. And this is what can we do? This is all we can do, waiting for the right pill, which does not exist at the moment, and waiting for the vaccination. The last word I will say is that the pandemic is not the problem. The intensive care is the last ring of a long chain. The pandemic has to be treated far before. When you have this disaster of so many patients coming to the hospital intensive care, this is simply because something wrong has been done or something right has not been done before in the territory. Well, thank you for the attention. If you have any question.
Professor Vincent, can you explain the corticotherapy in COVID patient?
Yeah, I understand. It's very difficult to give an advice about corticosteroids in COVID-19. We tend to believe that it's better to avoid it, in particular when we see the quite significant immunosuppression that these patients have, with a fall in lymphocytes in particular, and it may be dangerous to give corticosteroids. Now, there are some reports, and one Chinese report suggesting that it may prevent the development of severe ARDS, but it's usually considered that in the early stages, at least, it would be better to avoid corticosteroids. Now, if ARDS is really present and severe, we could again discuss the role of corticosteroids like in any form of severe ARDS. But there are some trials underway, and in particular in the United Kingdom, where the recovery trial evaluates dexamethasone in one of the arms. So we are looking forward to getting the results of this trial, but otherwise today it's usually recommended to avoid corticosteroids in COVID-19.
En cuanto a el uso de profilaxis con heparina o heparina no fraccionada en casos leves o moderados, ¿estaría justificado o no? Al profesor Vincent.
It's a difficult question. We consider that in general, there may be a place for relatively generous doses of heparin. However, some patients may develop severe bleeding, including when they require ECMO in particular. So obviously we need to individualize these decisions. But in general, we can be relatively liberal with the use of heparin.
Para el doctor Bugedo, no sé si en la experiencia de ustedes notaron que los pacientes que ingresan precozmente a la terapia, a la ventilación mecánica, van mejores que los pacientes que están en una larga estancia esperando un soporte ventilatorio. Que de alguna manera vemos en la experiencia, cuanto más precozmente es el soporte ventilatorio, los pacientes tienen mayor expectativa.
No, no lo creo eso, Jorge. No creo que haya que intubar precozmente a los pacientes. Creo que tenemos que evitar la intubación. Una vez que cae en el ventilador, sobre todo con la gran presión asistencial que tenemos ahora, no tenemos el personal óptimo. Los intensivistas nos estamos duplicando en diferentes unidades, lo mismo las enfermeras, kinesiólogos, de manera que la mejor terapia es la prevención. Y la experiencia con nuestros urgencistas es, desde que llama al paciente que llega con taquipnea, con desaturación, es invitar al paciente, póngase en prono, y le pones la bigotera, le pones la cánula, el aparato de administración que tú tengas disponible. Porque una vez que caes en ventilador, el manejo no va a ser el óptimo, porque estamos con una gran presión asistencial, de manera que los resultados pueden ser mortalidades, lo que dijo en un principio el doctor Vincent, sobre 50%. Eso no debiera ser bajo 30% si tuviéramos un sistema no estresado, con buenas guardias, pero en este momento estamos extraordinariamente estresadas. Entonces, estas medidas simples, como la posición prono, nos puede salvar vidas. Y ese es el mensaje. La intubación precoz para prevenir bajo ningún punto de vista.
Professor Vincent, can you tell about the tocilizumab?
Well, tocilizumab may have a place in the early stage of cytokine storm, as it is obviously an anti-IL-6 medication. So the studies are underway to evaluate the possible effect of tocilizumab and the anti-IL-1, either alone or in combination. So right now, we need to consider that these forms of therapy are experimental. I would not use it in a given patient like this. It's very, very important to conduct the proper prospective randomized controlled trials to have the appropriate answer to these questions. So right now, I would not really use any medication which has not been proven to be effective. At the present time, I would not prescribe any of these new agents in the treatment of COVID-19.
What happened in the L phenotype is similar or is different?
What happened where, excuse me,
in the L phenotypes?
Well, I think that L and H are not two dogma or type 1, type 2. It's just a word of communication. If I tell you L, you know that this patient with hypoxemic may be also severely hypoxemic, but with a flexible lung, which maybe breathes spontaneously, and maybe has some inspiratory effort. The key point, because it's not the only key point, but the only point that we might correct if it's the patient is breathing like this, despite the non-invasive support. If you leave the patient like this, the lung is destroyed. I can take an animal in spontaneous breathing for 24, 48 hours, breathing like that, and the animal develop what we call ARDS. And the same happens in the man. And we know that since 1938, go to the Barach papers in Annals of Internal Medicine, 1938. Everything is described there.
Dr. Gattinoni,
Hi.
hello, how are you? I'm
fine.
Nice to see you here in the webinar. Dr. Vallejo was asking about what is your opinion about the pronation in the patient type L and type H? What is the difference? I understand that the patient with type L is better to pronate because he's going to respond, because he's like the baby lung that you said in our conference. But the type L is like adult lungs that you said in the other conference, and this type is has very good compliance, so it's better. So, do you think that what is your opinion about the pronation in this patient? which is going to be better with pronation? You have to pronate only H and not L, or you can pronate L, for example, to resolve perhaps some mismatch in the BQ.
If you pronate an L patient, the L patient may pronate itself, so it's not a big problem, no? And some of patients stop the dyspnea, maybe starting with dyspnea, they feel much better, keep it prone. And ask the patient, do you feel better in proposition? Yes. You don't need a randomized study for that. You just ask the patient. And I know from several patients that stopped at the L stage, maybe because spontaneously they went in prone position. But of course, if the disease progresses, we can do nothing about that. And the patient start to have dyspnea, deep dyspnea, despite non-invasive ventilation, helmet, mask, and so on, the edema start to develop. The lung weight increase of half a kilo in one day.
What is your opinion about immortality in some ICUs? You think that this is related that the patient is not well individualized, it's like H and L, and when these patients go to mechanical ventilation, perhaps they are using some type of protocol, and perhaps the patient are only receive treatment at classic RDS, and this is the origin of the high mortality in these patients?
I think yes. Very simple. Let's see. I go in an hospital in the United States. I have some initial dyspnea. Let's see, I'm still in L type. So I'm L advanced, L plus. Okay. They measure my finger, no? And the saturation is 87. What they do? So if they intubate you and they start to look at the PEEP FiO2 table, which is very well validated, okay, you end up with 20 of PEEP. In the first week in Italy, in Lombardia, the average PEEP of the patient with helmet and so on was greater than 16. With this lung, that means you have 2-3 liters more. The heart becomes like this, and you start with noradrenaline. In 24 hours, the kidney is gone, and you have this problem. In 24 hours. So I think, the disease, the virus is the same in all world. Tell me why. Let's see, in Lugano is 10, in Bellinzona, which is 50 kilometers, no, 30 kilometers far, is maybe 50 at the beginning. You go in Algeria, and you have 100. You go in some unit in Greece, you are close to, don't let me know the name, also in Lombardia, you made sometimes 90. But you see that the mortality is going down now. Because the people is learning. And they say, why should I have a so big, so huge? But, and this overall my American colleagues, the North American colleagues. Oh, this is Evangelium. We have, where is your evidence? Here is our evidence. This is RDS because, well, barely definition, PO2 goes, bilateral filtrate, I PEEP test, PEEP table, 20 of PEEP. That's it. See you later. Then 88% mortality. Okay, good. If you are satisfied, go ahead. You have to understand what's going on. You have to explain me how it's possible to have 80 of compliance and 45 of PO2. Gas exchange in mathematics. If it's not the gas, it's the perfusion. I understood there was the perfusion after I've seen the first CT scan, the day 2 of the pandemic. Was clear to me that could only be perfusion, the problem. We don't need 3 months to understand that.
Thank you.
Which is still not clear, huh? Many, you see, there is an ideological battle at the moment. Okay.
What is your opinion about anticoagulation, Dr. Gattinoni?
Oh, anticoagulation, I think for all the autopsies. I went through about 150 autopsies in Brescia and in Bergamo. If you look at that, and you see that the anticoagulation, not the usual prophylaxis, but the anticoagulation in Italy now is done immediately. As soon as the patient, now in intensive care, but now even before intensive care, when a pneumologist so on, we start with full coagulation. Now, not at the beginning. At the beginning was a prophylaxis, but now the people change completely. And look in the patient, look at the behavior of the PCO2. Everybody speaks about oxygen, but the structure of the lung, the indicator of the structural damage of the lung is the CO2, is not the oxygenation.
Professor Gattinoni, I have another question here. What is the main factor for the production of PCL? When to intubate?
Okay, you have to, it's not so difficult. Let's see, you look at the patients, okay? The idea would measure the esophageal pressure, but nobody does it. Okay. But look at the sternocleidomastoidase, the contraction and so on. And you see that the patient contracts, huh? Maybe have the abdominal movement, which is abnormal, or sometimes the contraction between the ribs. And you say, okay, maybe you put the mask and put 10 of PEEP, okay? And then you look, and you see the patient continues his effort or not. You have to stay and look at the patient. If the patient continues or does not tolerate because the pressure is too high, at that point you consider the intubation and mechanical ventilation to stop this spontaneous effort, because even with the normal gases, let's see, the PO2 goes up, most of these patients continue with a tremendous drive, which is not depend only by the hypoxemia, but also by the infection in general. So the drive is not only dependent on the hypoxemia. You correct the hypoxemia, the drive continue despite the non-invasive support, consider intubation. And I think that the consequences of an intubation inappropriate early, maybe, you know, sometimes, okay, maybe you should have avoided. But the mistake you can do doing an inappropriate early intubation versus the problem you have with the inappropriate late intubation, the delay of intubation is more dangerous. You know, sometimes when you measure, you see that this patient may have up to 30 centimeters of water of transpulmonary pressure. That means at each breath, they are almost at total lung capacity. And this is tremendous for the lung. For an inflamed lung is terrible. So we have to interrupt this. And this is the only thing we can do, by the way. You can do nothing else. We cannot stop we don't have the magic pill. We have to keep the patient alive without damage, to buy time, with the minimal damage possible.
¿La tormenta por citoquinas también suma para que el SARS-CoV migre a una forma H o solo es por una autolesión ocasionada?
Oh. Let's see. Now tell me if I'm wrong, but I think since I was studying medicine last century, many years ago, the people will say, what is a sepsis? Sepsis is an overwhelming reaction of the body to the host, okay? Which now is called cytokine storm, which is new name for an old observation from Oslo. Then for at least 10 years, we try to use all the possible anti-inflammatory drugs, anti-here, anti-there, cortisone, alpha-tonus cortisone, anti-receptors, anti-cytokine, interferon, blah, 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 to stop the reaction. Which was the results? Zero. Now, this is nothing else than, at the beginning, let's call a localized sepsis into the lung. Stopping the inflation never succeed, in my experience. Maybe for some miracle, this time will do, but I don't believe to that until I see it. And I don't think I will see that. Because remember that when you stop one cytokine, you may have also, and the people looking at the cytokine before, as an example, apply cytosorb, they found a very high level of IL-6. A friend of mine, but in 5 patients, the level of IL-10 was 0. The level of TNF was 0. So the anti-cytokine, the anti-inflammatory, is completely down. So where is the truth? You are too ignorant to try to touch this terrible storm of the language of the cells. And I think the risk to do something dramatically wrong is greater than to do something dramatically good.
Professor Gattinoni,
Yes?
what do you think about recruitment maneuvers in ours for ARDS COVID?
Well, I can tell you, in state L, it's completely different because you don't have nothing to recruit. Because you don't have practically non-aerated tissue. We measured that. In later status H, now we have about 32 patients which we went to look carefully to that. The recruitability is very low. But anytime we increase the pressure, the compliance goes down dramatically in these patients. So I personally would not use the recruitment maneuver in this case. And if I use, not go more than 35 centimeter water of pressure. Don't use the 45, 60, because the pneumothorax in a lung which is full of microthrombosis, the lung become a sort of emphysematous lung. Would you do big recruitment maneuver in an emphysema? The baby lung is not the baby lung, become an adult baby emphysematous lung. And we have a lot of proof of that. We are preparing a paper that will be rejected by all my American colleagues, but who cares? I think the reality is not all, some.
Yeah. Dr. Gattinoni, a question. Do you use the prone positioning in non-invasive mechanical ventilation or in high flow nasal cannula?
Well, not high flow nasal cannula, no, non-invasive. You know, the point is there is not the right treatment for this disease. Exists the treatment which is more appropriate at certain stage of the disease. When you have an L patient, just to understand that, to explain ourselves, that means the compliance is still good and just hypoxemia. Okay, you can put in prone. You may give some oxygen. You can use high flow. You can use CPAP with ailment. You can use whatever you want. But to me, you have to look how the patient reacts to that. The PO2 goes up, always. But the patient continues the big inspiratory effort, yes or not? This is a key point to me. And nobody look at that. The people say, what is the right intubation? Tuesday instead of Wednesday and so on. Look at the patient in that particular condition. And I repeat for the fourth time, this, by the way, is the only thing we can do to prevent a further damage. We cannot do anything else. We cannot cure. We buy time with the minimal damage. And I think the patient breathing like this, the damage is around the corner. Ciao, Guillermo.
It's a new disease. I mean, it's COVID. If it's ARDS or not ARDS, which phenotype, I mean, it's just semantics. Y es distrés o no, es problema semántico. Tienes que...
Guillermo, I agree with you with this semantic, but when the people look in that semantic, open the book and look at the tables, the semantic may become very dangerous.
Yeah, sometimes. Yeah, they could
okay, be. So be careful with the semantic. For me and you are absolutely semantic, and I fully agree. And you can call people, can call Mickey Mouse, can call whatever you want. I don't paranoid for the RDS, yes or no. But the consequences of this semantic may be devastating.
Doctor Arias, de repente usted podría hacernos un resumen de todo lo que el profesor Gattinoni ha podido decirnos con estas preguntas, de repente enfocar los puntos más resaltantes.
Bueno, yo creo que el doctor Gattinoni ha hecho una revisión excelente y para empezar, yo creo que debemos darle el agradecimiento de la sociedad por habernos acompañado esta tarde y ha hecho varios puntos importantes que debemos tener en cuenta. Nos ha hablado mucho del trabajo respiratorio, que el trabajo respiratorio es importantísimo de vigilarlo, incluso tan igual que la gasometría. Nosotros a veces cometemos el error de mirar la gasometría y mirar, como dice el profesor, que la gasometría está bien, pero el trabajo respiratorio está totalmente incrementado, y eso al final lo que va a hacer es aumentar el daño pulmonar. Lo que estamos haciendo es de que esa enfermedad vaya progresando, y como dice el profesor, lo que estamos haciendo es encaminándonos a una intubación tardía. Entonces, importante definir, una cosa es la hipoxemia, el daño en la microcirculación es importante, pero el otro es el daño que se está produciendo, autoproduciendo el mismo paciente, ¿no? Eso es importante. Lo otro que es importante, y eso también veo que pasa a veces, lo veo en alguna de nuestras unidades, es que cometemos el error de tratar como los tres, como dice, y no diferenciar de que hay una forma L y una forma H. A veces queremos pronar a todos los pacientes y no es así. Hay un grupo que tiene que recibir, como dice el profesor, más volumen, un pulmón blando, y eso puede ser 7, 8 mililitros por kilo. Y ese pulmón se va a distender, porque si lo no se va a telegraciar. Y si le ponemos pipa a ese volumen, ese pulmón va a explotar. Entonces vamos a hacer de que ese pulmón se dañe más. Eso es lo que el profesor en una de sus conferencias dice, es un adult lung, no es un baby lung. El H es el baby lung, el clásico RDS. Eso es como el profesor lo ha escrito. Y a ese sí podemos tratarlos con ventilación protectiva, ponerlos con pronación. Ese es beneficiar del manejo clásico de RDS, pero el otro no. Entonces hay que tener bien presente eso, ¿no? Y tener presente de que hay puntos en los que podemos actuar para tratar de prevenir el avance de la enfermedad. El H y el L al final son periodos de la enfermedad a la que estamos dejando avanzar. Tenemos que reconocer que el profesor ha hecho una excelente presentación.
May I give you just one information, because I forgot what is important. The people discuss about compliance. All the numbers I give in compliance and we publish were measured in standard condition of PEEP of 5. If I measure the same patient at PEEP of 15 of 20, the compliance may be very low because it's an emphysematous, become an emphysematous lag. We are looking, my dear friend, now we have 33 patients with COVID. We match with 32 with RDS from pneumonia, and we match with 32 with extrapulmonary sepsis with RDS. Now, just to give one number, the patient with pneumonia, RDS from pneumonia, the gas volume at 5 of PEEP was 600 milliliters, the baby lung. Here, at 5 centimeters of PEEP, which works gas exchange, the gas volume was 1 liter, 0.6, 3 times greater. If the people say it's the same thing, I'm afraid it's not true. So the time of observation and the way you measure the things is crucial. I'm speaking all the measurement and number I gave you were kept at standard condition. 5